Welcome everybody to the second palliative care session for the 19th Shaukat Khanum Cancer Symposium. It is a pleasure. The last one session we had on Friday was very well attended and a very good and robust discussion was done on very interesting cases shared by the panelists as well as by us. So following the success of that meeting, today we are going to be talking mostly about a topic which is I think it's very important for the state of palliative medicine in Pakistan, which is training opportunities and the way forward to improving the access to palliative care in Pakistan. We have five invited speakers today, which will, one of them is my own self. Then we have Dr. Chris Farnham, who is a consultant in palliative medicine at the Baths NHS Trust London. Then we have Dr. Fiona Rowlinson, who is associated with the Cardiff University. We also have Amy Prothre, who's representing the Royal College of Physicians of London, and Ian Laurie from the Association of Palliative Medicine of Great Britain and Ireland. So I hope that it will be an interesting session. We'll all have 20 minutes for our talk, and then we'll have about 10-15 minutes to do a discussion on what we feel is the way forward after listening to what everybody has to say. So as I said, the main theme today is going to be about uh, the state of palliative medicine education in Pakistan. I'll start with my own talk, and if you just give me a moment, I'm going to try and share the slides. If I could just ask anybody from the panelists to confirm if they can see my slide.
Yes, see that.
Okay, great. So that's working. That'll be fine. So I'm going to try and talk about the training opportunities for palliative medicine in Pakistan. For those of you who don't know me, I'm currently working as a consultant physician in palliative care and internal medicine at the Shaukat Khanum Memorial Cancer Hospital in Lahore. Before I go on to delve deeper into what training is currently available in Pakistan, I just thought as a bit of a revision, I'll quickly go through what palliative care is all about and what we really mean when we say palliative medicine, what sort of a branch of medicine it is. I mean, probably my opinion is biased, but I feel it's one of the most integral part of medical care, and it's not new. It's always been there, and it has always been one of the most important aspects of delivering good medical care. And WHO decides it as a branch of medicine more concerned with the control of symptoms rather than with the control of disease. This slide, I'm just trying to show that it encompasses a lot of things. It's not just about medical management of the disease, which is covered in the symptom relief that we provide. It's also about spiritual and existential care. It is also about advanced care planning so that the person who's suffering, the patient, feels in control with regards to his illness if they are able to do advanced care planning. It's also about bereavement support. So it's a whole facet that encompasses the entire disease trajectory. And it doesn't finish. The association with the patient and the family doesn't finish if the patient passes away. It extends beyond that to bereavement support. A lot of people think it is only for cancer patients, which is not the case. Although primarily my practice in Pakistan is focused around cancer patients because I work in a cancer hospital, but we have to realize that palliative care is not just about cancer patients. It's about all these chronic illnesses, a few of the examples that I'm showing on the screen at the moment. Um, um, at the moment, if you look at this diagram, this is one of the ways in which they try to depict how palliative care should be integrated into primary and secondary healthcare. The prevention part of your health would probably be primary healthcare. Once you are diagnosed with a chronic illness, your input as a palliative care team is very minimal, whereas the curative team like cardiology, oncology, pulmonology would have a much bigger input. And then as the disease progresses, the input from palliative care increases. And what I want you all to notice in this slide is that the input from palliative care doesn't stop at the death of the patient. It goes beyond the death to cover bereavement and grief as well. Um, Now coming to Pakistan, we have 21 cancer hospitals at the moment, and about 50 general hospitals who have the facility to treat cancer. And amongst these 70 centers, less than 10 facilities, I am aware of about five, but I always say less than 10 because there are one or two facilities that are not on the radar and we probably miss them. But we know for a fact that it's definitely not more than 10 in the entire country of 200 million with some sort of palliative care facility available. At the moment, we have about 125 trained oncologists, which is very, 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 you know, uh, not sufficient for the population that we have. But compared to that, we have less than 10 trained palliative medicine physicians in the country. So currently, where we stand, it's not looking very good in terms of access to care. Um, what are the reasons for it? There's not much educational opportunities available for palliative care in Pakistan. And one of the major reasons for it is that it is not a recognized specialty in Pakistan. So I, for one, and my other colleagues who practice palliative medicine or palliative care in Pakistan are not registered as palliative medicine specialists. We are registered as either geriatricians or internal medicine specialists, because the postgraduate college and the licensing authority in Pakistan do not recognize palliative medicine as a specialty at the moment. Similarly, to the best of my knowledge, and we have conducted surveys at various points in time, the undergraduate and postgraduate curriculum for nurses and doctors does not contain formal palliative care education delivery or modules to be delivered and passed before you can work towards your degree. There is mention of palliative care in some undergrad programs, some medical schools, and some postgrad programs as well. But what I find interesting is that I don't know who teaches that, because I've often spoken to the 5 or 6 out of the 10 who I know work in palliative medicine in Pakistan, and I've never been told by any of them that they've been invited to any undergrad nursing or medical curricular coverage. Similarly, very few educational institutions in medicine and nursing have palliative medicine setups. Um, uh, Shaukat Khanum has tried to establish a training program, a postgraduate training program, but it's currently a hospital-based fellowship. I'm very grateful to Atif Wakar and Akhtas, who helped me write out a curriculum for the College of Physicians and Surgeons of Pakistan, which we submitted to them about a year and a half ago, and it is still lying gathering dust on their desks. But every now and then when I go and meet them, they say, oh, this has been signed by the president, now it needs to be signed by so and so, and it'll get done. But so far, in about 16 months, the progress is quite minimal in terms of getting palliative medicine formal postgraduate degree started in Pakistan. So for doctors, as I said, essentially, I would say none. Some people may disagree with me, but I think very patchy programs exist. Probably Khan has a patchy program. We have a very patchy program, because there's no formal recognition from the postgraduate institutes and the licensing authorities in Pakistan. Similarly, for nurses, again, I am aware that a couple of nursing colleges have started palliative medicine workshops, but they are not mandatory to attend for anybody to get a license as a registered nurse. Um, so why do we need it? Why all this discussion? From a patient perspective, palliative medicine is about improving the quality of life. It is about getting on top of their symptoms, and it is about helping these patients cope with their disease. And I think if we speak to any patients with a chronic disease, I doubt any of them would negate these three very important aspects of management of their disease, regardless of whether it is a terminal illness or not. But anybody with a chronic illness wants to improve the quality of their life. They want to know how to cope with the disease. And I'm not saying that the other specialties like pulmonology, gastroenterology, or oncology do not know how to do this. I'm just talking about that the emphasis over there is more on curative therapies than with dealing with these issues. Similarly, from a patient's family perspective, they need to be able to get the support when they require to understand how the disease is working, what to do in terms of symptoms, how to manage those symptoms, and how to help the patient cope with the disease. and most importantly, when they lose a loved one, how to cope with the bereavement and the loss of a loved one. Um, from a healthcare perspective, I often, when I take this, or when I, if I give this, if I was giving this talk with a live audience, I often ask people to raise their hand to show me how many healthcare professionals have dealt with a dying patient. And often 99.9% of the hall will raise their hands. But when you talk to them about how many of you have had formal training with regards to end of life care, very few are able to hold their hand up on that, at least in Pakistan. And I feel that is very important, because all of us as healthcare professionals will deal with death, and we need to be able to be trained in end of life care. We need to be able to train in improving the quality of life of patients with chronic diseases. And most importantly, palliative care training also encompasses a lot of training in communication skills and all of these things, which are essential for us for providing good patient care. So where do we lack at the moment? So first of all is awareness. There is no awareness in the general public about palliative medicine. People don't know what palliative medicine is about. People don't know when to seek care from a palliative medicine specialist. And most importantly, most healthcare professionals don't know when to refer to a palliative medicine specialist. So not only do we need to raise the awareness on public forums so that, the general population is made aware of what palliative care is about, we also need to raise awareness among healthcare professionals about the importance of this field and the importance of referring or timely referring to palliative medicine specialists. Currently, we also lack good palliative medicine setups, departments in bigger hospitals or standalone hospices as we have in the UK or the world. We do not have much of that over here. We have 2 or 3 standalone hospices in the country. But as I said, if you talk of a population of around 200 million, this is nothing. Trained palliative medicine physicians, I've already mentioned that I am aware of less than 10 trained palliative medicine physicians working in the entire country. Trained palliative medicine nurses, again, it's a huge dearth. Whilst we do have nursing, nursing per se is not that good, the nurse to patient ratio in the country or nurse population ratio, but specifically trained palliative medicine nurses, I think that's a very, very rare thing in Pakistan. Most importantly, it's not recognized as a specialty. And because it's not recognized as a specialty, young doctors and nurses training, while they are training as doctors and nurses, they don't see it as a career pathway, because there are no departments in hospitals, in government setups, where there is a career for a palliative medicine specialist. So nobody obviously is going to opt for training in that, even if we were to start training in palliative medicine. So where do we start? I think we should start with public awareness sessions, contact sessions, write-ups. Recently, I've been working with a very kind family who have been spending a lot of money on making a documentary of introducing palliative care in the country. So we hope that might work, and we plan with them to write articles and letters to newspapers and things like that. The other thing we need to do is establish palliative care departments and hospices all over the country. That is a bit far-flung approach, keeping in mind that we do not have the professionals to staff that. But most importantly, and that's why I've underlined it, we need to start or consider recognizing palliative medicine as a discipline of medicine, so that people see it as a career option when they are training in medicine and nursing, or anybody who's training as a healthcare professional sees it as a career option. And that can only be done when you introduce palliative medicine curriculum at the undergrad level. When they are being exposed to all branches of medicine and nursing, they should be exposed to a little bit of palliative care as well, because as doctors and nurses, they will always be dealing with patients with chronic diseases and dying patients, and that knowledge will help them be better doctors and nurses. But also, when you deal with or study about these things at an undergrad level, it helps develop an interest to pursue at a postgrad level later on. And obviously, we need to think about setting up postgraduate medical and nursing training in palliative medicine, which does not exist at the moment. And not just the training, there are a lot of other issues, but in the interest of time, I'm not going to dwell much deeper onto that. Infrastructure we've covered in terms of lack of setups and lack of hospices. Human resource I've also covered, because we don't have the right number of professionals that we need to be able to say to the public that we can give you good access to palliative care. There is inadequate training programs. We've already discussed that. Availability of drugs, again, a very, very sore point in this country. Unfortunately, all we have is long-acting morphine tablets and fentanyl patches and some parenteral opioids and nothing else. Whereas the world has really advanced into the drugs needed for essential palliative care. Most of the drugs on actually the WHO essential list for palliative care are not available in Pakistan. And there is a very low research output, which is obviously secondary to the dearth of training and trained professionals. Obviously, when there are not enough trained professionals, there will be very little research output into that field as well. Um, I want to propose, and we'll see what the rest of the panel says at the end of the discussion. But what I want to propose as a way forward is that we need to raise awareness. We need to start building on the infrastructure available. I feel it is very, very important for us to try and introduce palliative care modules at undergrad level for doctors as well as nurses. I am aware of a group of professionals from UK who formulated a Shaheen palliative care project, who are working very hard with some universities in Pakistan to do that, and they have had some joy so far, but it's still a very long way to go on that end. I feel that for institutes where we have palliative care, postgraduate trainees should rotate through that. That might generate interest. Plus, it might also help deliver at least some basic minimum training to other professionals dealing with patients with chronic disease. We need to work towards recognizing a training program. We need to work towards awareness campaigns for general population, and we need to improve the access and availability of at least at the bare minimum, the WHO list of essential medicines should be made available in the country. I also want to touch here on what I feel that Royal College, because we have a representative from the Royal College here, and we've been working together with them to promote the cause of palliative care in the country. So the role I feel that the West and the Association of Palliative Medicine and Royal College can play is help us in faculty training, help us in designing a curriculum. We have actually used the Royal College curriculum for palliative medicine as a baseline, on the basis of which we've designed one and submitted to the college here. But most importantly, designing and delivering exam content. We are only 3 or 4 people who are working on this, and that's probably not enough to lift the specialty and off the ground in the country. I feel, UK has a very good and developed palliative medicine setup, and maybe we can, try and work on opportunities for trainees from this country to go and spend some time there in established palliative care centers and hospices, and then maybe come back and help train people here. Most importantly, it's very important. I know the International Association of Hospice and Palliative Care has these fellowship and support scholarships that they give for attending symposia and workshops in UK. So I think that's also something we should tap into in this country, and for people who are interested to help them in write out an application to get those grants. So in the end, I'm just going to say is that, we should not take dying as a failure. It is dying with loss of dignity, with distressing symptoms, which should be deemed unacceptable in today's day and age. And with this, I will end my talk. And I think what we'll do is we'll take questions in the end. So what I'm going to do is I'm going to invite our next speaker straight away, which is Dr. Chris Farnham, who's a consultant in palliative medicine in the Baths, and he is going to speak about training opportunities and online and distance learning. Chris, do you want me to share your slides from here, or are you happy to do it yourself?
No, that would be great if you're able to. Thanks again, Haroon.
Okay, rightio. Can you see your presentation now, Chris?
Yes, I can actually. Thank you.
Great. So over to you.
Shall I ask you just to, you've got control over the slides, I presume?
Yeah, I do.
So if I just ask you to change...
Yeah, if you just, yeah. Do you want me to change this first one, or?
In a second. Thank you. Just thank you very much for asking me to speak. I'm probably the world's worst person that you asked to speak on this particular topic. So I am warning you all. So I am coming from a completely ignorant perspective about distance learning, particularly using the internet and as you will find out, but in a way that is a strength, in as much that I can describe some of the learning that has been derived from the last few months, and I'll try and share some of that with you. And you're about to hear from people a little bit later on who know far more about this and are far more they've got far better information about this than I have, but I'll try and share some of our learning from where I work. So next slide, please. So we're going to look at it in just three ways, very simple, very basic. So what is it? Why is it? And when does it get used? This is our remote teaching and learning. Thank you. Next slide, please. So first of all, why? Well, we know that COVID has really changed the way that we all live, work and play. And that is likely to be like this for a very long time. I don't think this is going to change. So what was it like before COVID? I'm sure we all remember very large teaching opportunities like conferences such as this, where it was great. We'd all spend time away from home and our work, and we would meet up with our friends, our colleagues. We would have large teaching rounds, perhaps in the hospitals. We would go to grand rounds where we would teach and we would listen to colleagues speaking. And it was great. And it was what we were all taught to do. So those of us who do teaching, we were taught to teach in this way. I certainly know in the UK, there was all the teaching modules that I went on were either about bedside teaching, group teaching, and lecture teaching. So it was based on face-to-face teaching. And the stance that I took was based on decades and decades of medical teaching. And suddenly all of that changed overnight. When we went to conferences, if for whatever reason, if we were given a short video to watch or there was a little bit of online content, we somehow felt that the speaker had opted out. It was their sort of way of dodging the bullet. And they were giving us something that we could just close our eyes for a bit. We could sort of just start thinking about other things, or we felt a bit shortchanged. We had a nice lunch. We would have breaks where we would all go and have coffee and chat to each other. And for me, some of the richness of these meetings was exactly that. It was about catching up with people that I hadn't seen for years, hearing about what they were doing, how they were coping, what was working, what wasn't working. And it was, as I say, the richness of all of that, apart from all the speakers and the lectures that I went to, it was the stuff around it that actually was of great worth. Equally, it provided time away from the work environment to de-stress a little bit, and it also gave us time to think. So we've lost an awful lot of that. And can we gain some of those things back again through this online environment that we've suddenly found ourselves in? So next slide, please. So what are we doing? Well, we're using a whole bunch of new platforms. That should say Starleaf rather than Silverleaf, apologies. And we're using these new platforms to deliver our teaching and our learning opportunities. They're variable in quality, probably because we're still learning how to use them effectively. And in our teams, we're using them very differently. There are new rules that we've all had to learn. And certainly in the beginning, the number of times that people used to say, Chris, turn off your microphone. So I'd be having conversations thinking nobody could hear me, and it got me into a little bit of trouble in several occasions. So we have to learn these new rules of engagement with each other using these online platforms. The opportunities for snore time, I've said this in as much that when, as I'm sure all of you are, you're suddenly all sitting up now, but nobody's looking at you. So in the old days, if I had a lecture theatre in front of me, I could see everybody, they could see me. I could see if it was going well because they would be engaged, they'd be looking at me. If it wasn't going well, there'd be one or two who would inevitably start to snore, to go to sleep, or look at their phones, or be talking to each other. But there's so much one-to-one engagement, and you got that real-time feedback. So now, as I'm sitting here, actually in my garden shed, 1,000 or so miles away or more from most of you, I have no idea what any of you look like, what you're doing, and really disconcertingly, all I can see is me. So again, in the old days, I would be a little dot at the bottom of a big lecture theatre, and you would be a sea of faces. Now you can see me in, unfortunately for you, in Technicolor, and you can hear me, but I can't see you. And that is a very different way of delivering education. Slightly disconcerting initially, and slightly getting used to it now. So competing spaces, it's often very difficult, isn't it, to find a time and a place where it's okay to do this. So for me in the UK, it's early morning, so I'm not waking up the house, I'm sitting in the garden shed doing this. And equally at work, sometimes it's quite difficult to find a quiet space where people won't keep barging in. Thank you. Next slide. Haroon, I don't know if you can just tap down on the next slide. Thanks. So given what I've said, what makes excellent teaching? What, in my experience, what has been good? So it's all about planning, and that comes through certainly in a session like today, when I suspect all of you have had tons of emails prepping us for this. So excellent planning leads to an excellent learning opportunity. Haroon, this is where I suck up to you a bit. So good chairperson, this has been great because you know who's in control, our mics are switched off, our videos are switched off, we're being managed. And that feels like a very organized session. We know what we're going to learn, we know what the outcomes are, we know what the plan for the session is, who's going to talk when and where. So the rules, it's really important that everybody understands those rules. So in the beginning, it was a bit of a free-for-all, not in this session, but when we started doing these, I know we had lots of us, we were chatting away, people couldn't hear what was being said, people were joining late. So really agreeing those rules and people learning those rules and abiding by them makes a very good session. Equally, we've all found that we all need individual logins. And again, early on, I had some very interesting experiences of being in meetings where we thought these were medical meetings and members of the public had joined into our meetings. And there were some very distressed people who were taking part in those meetings. And we hadn't expected them to be in because a general login had gone around. So we get around that, as we do with these kind of meetings, with individualized login. So you know who your audience are and who's in that audience, hopefully. Great IT facilities and equipment. So having a good camera so people can see you properly rather than having a very blurred image makes a big difference. Very good Wi-Fi, good broadband width. I must say, to our own shame and our organization, when I've been doing teaching abroad in countries that perhaps aren't as wealthy as some of the other countries, they generally have fantastic IT facilities and equipment. And I suspect that's because people have actually embraced this technology in countries with fewer resources far better than better resourced countries where sometimes we just rely on what we've already got and we sit on our laurels. So I've been just hugely impressed with the IT facilities and equipment that people have been using and developing, often in countries very far away from where I've been teaching. So having a good space and time set aside for your teaching. And then really, finally, this is again where you all sit up, engagement from participants. So making sure that, as well as the speakers being well prepped, that people who are joining and taking part in these learning opportunities, that they're not sort of multitasking. It's so easy when you can switch the screen off, you can switch the sound off, nobody's watching you, you go off, you make a cup of tea, you have breakfast, you have lunch, you multitask on your phone with other bits of IT, or you're looking things up, or the kids wander in, or the cat goes across your computer. It's not like being in a lecture theatre where you are slightly more forced into engaging. And so it's very easy to disengage and to lose some of those learning opportunities. So it's very important that as a participant that we know that we are still expected to engage. Thank you. Next slide. So I just want to share a couple of examples of this sort of distance learning that's worked for me. Recently in London, Kent, Sussex and Surrey, which is our deanery for teaching palliative trainees, there are about 25 or 30 trainees who were being taught. And it was the first experience I'd had of teaching our registrars remotely. It was great. It was absolutely fantastic. They had organized it and they were so engaged. What really struck me was often in quite a large group of trainees, there will always be those who come to the front to ask questions and can dominate in learning environments. But what really struck me, again with the STRs, was that people perhaps who were a little bit more introvert and quieter could post their questions very easily without feeling exposed in the same way online. And so in a way, there was far more engagement from all of the trainees using these distance learning techniques than perhaps would have been so had we done face-to-face. And the feedback that we got back really represented that as well. So there's much broader feedback than we would have had if we'd done some of the face-to-face teaching. Another example is, I don't know what it's like elsewhere in the world, but a lot of our general practitioners have now stopped doing as many home visits as they once did and are very much based in their surgeries. Now, I go to a nursing home once a week. There are about 86 people in there that I go, don't see all of them every week, but a lot of them are end-of-life care and palliative. And we now take the GP round with me and with the nurses to go and see the patients. And I learn from them, they learn from me. Before, I would never have had a GP for an hour and a half. I now have a GP with me for an hour and a half. So I take their expertise with me to go and see the patient, and we can share experience and help each other. So prescribing drugs, getting things set up, doing advanced care planning, and having conversations with relatives as well. So we can do Zoom meetings with relatives. It's a huge, huge change from what I did before, but it has brought an enormous richness to those rounds. As I said, this conference, just fantastic, really great to see so many people engaged and some really excellent conversations. I've put down here clinical support for clinicians. So myself and the other doctors in our service, we have monthly supervision. Previously, I've always done that face-to-face with a Jungian analyst, and I would never have contemplated doing that remotely. So I always used to drive to her house at the end of a working day once a month, and I would have my 50 minutes of supervision with her, and then I would go home to think about what we'd talked about. But now I do that at work, and I do that remotely, and I actually prefer it, and I'd never, ever have thought that. It fits in with my other commitments. I always thought I needed time afterwards just to decompress from what we've been talking about and think about that. But actually, I've learned to deal with all of those things in a very different way, as have all of us, and it saves an awful lot of clinical time and is just as effective. Finally, just some other things that we're using, technology, really delivery of services. There is some teaching in there. Are less direct patient hands-on care services, using very bad English, apologies. So our psychological support services, our therapy services have all switched to online support for patients. And I thought people would find this really difficult from a patient and family perspective, but not so. People really appreciate the connection that they get with these online services. And again, in the same nursing home I go to, every new patient that comes in gets a tablet. That's an IT tablet, not a tablet, a pharmaceutical tablet. So they get an iPad, and that means that the family can see them whenever they want to. Equally, the home has given relatives access to all their IT systems. So families can log on and see when the nurses fed the patient, when they gave them their drugs, how the patient seemed, what their symptom control scores were. and they can see real time what's being done to their loved one, which is great. And finally, our multidisciplinary team meetings. So I work with the respiratory physicians and go to the lung meetings, and having a radiologist at home who's going through all the scans, a histopathologist going through the histology, the oncologists in one hospital, the respiratory physicians in ours, and myself and the nurse specialists in another setting, all logging on together with really good learning, it is fantastic. The slight fly in the ointment is that we have a generator test right in the middle of this. So it starts off being excellent, and then the hospital switches off all the electricity for 30 seconds to test the generators, and we lose our control. And that's an example of finding the right time and the right place. Clearly, our time isn't the right time. Next slide, please. I'm almost finished. So finally, make sure that everyone knows when it's happening. As we've been excellently communicated with here, we all knew when to start. But they also know how to log in. I've been to meetings even this week in our hospital where it took people 20 minutes to get the IT and the log on, and we've lost half of our learning opportunities just because people were poorly prepared. Not so in this case. Dress code. In the early days, we had one of our team who turned up to a meeting in pajamas. I don't know if they thought we couldn't see them, but it was really quite off-putting. And slightly later on, one of our team leaders who was logging in from home, she was in her garden with a glass of wine. And again, that probably wasn't appropriate. Thinking about your background, it's really important to know what's behind you. I must say, it's very disconcerting when you're trying to read what people have in their bookcases, or see what their paintings are or pictures behind them, or if people are going back and forth. So try and find your space, be aware of your background. And if it goes wrong, have you got somebody to help you? If you've got 30 or 40 people listening to your talk and suddenly it all freezes or you can't share your screen, is there somebody there to help? Because if not, then you're wasting 30 or 40 people's time. Next slide, please. So when it goes right, you've got good connection, both physically and otherwise. People listen to what you're saying, they can hear you. So sound is vitally important. Having good speakers, and that's, when I say speakers, I mean people, well, good speakers as in sound, but good speakers as in people who know what they're talking about and how to use the technology. So it's down to preparation again. So when your speakers can start at the right time, they don't lose their slot or their session because they can't log on, and you can hear them because they're well prepped at their end, that makes for a good learning opportunity. Good questions in a timely manner. So rather than them butting in and you're losing time, using this technology means that those questions can be concentrated in the right time, in the right place, so that they get answered. And having some kind of recording so that people can log in later to listen to that session again, just to check what they heard, it just reinforces the learning. And any opportunity for feedback, certainly we found, has been great. People feel much more connected with the session if they're able to give good feedback. Thank you. Next slide. And very finally, there are just two little bits of reading that might be useful to you. One was from a couple of weeks ago in the BMJ about in primary and secondary care, really top tips about how you can use these learning opportunities. This is about consultations, but most of that information is usable in the teaching field. And then finally thinking about how COVID has affected medical education. And I know that this is going to be talked about later, but one paper there for you to just spend 5 minutes reading. So thank you very much. That's the end of my talk.
Right, great. Thank you, Chris. That was very good. And you stuck to the 20 minutes as well. So that's great. Thank you for doing that. Next, we have Dr. Fiona Rawlinson, and she's going to talk about mentoring from a distance. And she's a consultant in palliative medicine in Cardiff University. She's going to talk about mentoring from a distance experience with a cohort of students from Pakistan. And we are very grateful to Fiona because I know at least 3 3 of our 4 faculty members at some point in time have been attending her classes and have been tapping into the wealth of knowledge that she possesses and is willingly sharing all the time. So thanks, Fiona, for all your help as always, and thank you for coming here to talk. I'm just gonna, do you want me to do the screen share, or are you going to do it yourself?
I hope. I might have just done it.
Great. Yeah, it looks like you've done it.
Just done it. Okay, fantastic. Thank you, Haroon. And gosh, how to follow and how best to really encapsulate what's been the most amazing experience over the last 3 years. So I'm really honoured to be invited to be part of this conference and this session. So I'm just going to spend a little while just talking about really the experience since 2017 of a regular link up with colleagues from Pakistan, how we set it up, what the aims, what the basis of the sessions have been, and some of the challenges we've mastered along the way. And then in fact, to follow on from Chris, just actually the opportunity that COVID has given us to think about technology in a different way, and to think about the imperative really of using technology. Palliative care is so very much needed around the world, in Pakistan. So we can't let the virus stop our educational opportunities. And in fact, in a quirk of fate, in a way, I think COVID has opened up a lot of very, very exciting opportunities. So I've spent decades now embracing and being really excited to be able to be part of and contribute to the global palliative care community. The humanity aspect of palliative care, as Haroon was saying in the first session, it's an imperative. Just because people have an incurable disease and their life is going to finish, or they thought it was going to, we need to focus our attention on them just as much as for the curative treatments and for disease management along the way, because we know that for the people left behind grieving, if the journey, the palliative journey of their loved one has been reasonably straightforward, grief is grief. You can't make grief anything other than grief. It is a thing that we all have to go through, but it is a smoother transition, and it's part of life. I think that's the other unexpected thing that COVID has done to all communities across the world. It's bringing an appreciation of the risks of life, if you like, coming to an end. Death is very much more on people's agenda. So I've been in by quirks of fate. It's not by design, really. I've just happened to be able to be part of the Cardiff University diploma course during my training years, and through that develop links across the globe, really, at various levels. There's a family saying in my family, when we were growing up, I'm the youngest of the family, and there's a family saying that if anybody sat still long enough in the house, I'd want to help them to learn to do something. And there's that thing about sharing the knowledge. There aren't many palliative care physicians, nurses around the world. So those of us who are interested in it, we have to be ready to share that knowledge. You never know when even one conversation will change the course of a healthcare professional colleague to understand palliative care issues and then give better palliative care to patients. So really, I think the themes which led me to 2017 have been thinking about education that helps develop communities of practice within the setting, within the town, within the country. It's connecting people. Linking education with in-country organisations, or supporting the development of that community of practice, which then becomes that in-country organisation. Building on foundations already present. We're very lucky in the UK. This is where Dame Cicely Saunders started everything off. But actually, across the world, there are palliative care initiatives, and really important to start to build on those. So thinking now of colleagues in Pakistan, we've now you've got a groundswell. So it's thinking of how to capitalize on that. Using the Jan Sternwald model, which I've got a slide on in a moment, that has been across the world the foundation stone of developing palliative care. And it's still as relevant today as it was in 2007. Immense respect for the different settings, the different resources, the different availability of human resources of drugs. I've learned enormous amounts about diversity, about the role. Diversity is good, it's not something to be threatened by, but one needs to understand it and see the strengths in it. Coaching skills, really important skills, and I think starting to be part of a mentoring set, if you like. The mentors need to have very clear understanding of our coaching skills, and that's a skill that one develops over time. Personal professional skills have undoubtedly developed by being part of this international community and understanding the context in which palliative care is. So, for example, I did a lot of work with the University of Cape Town setting up their master's course with colleagues in the early 2000s when HIV/AIDS was rife in that country. So our ethical sessions, for me, quite a young consultant at that point, coming from a UK background, going into Cape Town and thinking about the ethics of consent, of all the kind of the context and the traditions, that was a really useful learning opportunity for me. So there's a lot of experience on which to base, and a lot of technology. We were instrumental in starting off some online learning for sub-Saharan Africa and 20 modules for India, which we filmed within those countries using the expertise and learning such a lot along the way. So I think mentoring, doing things internationally can be a really enriching experience. I hope for the participants, but certainly for anybody involved in the projects. This is just a slide to remind people, and this paper is still what developing palliative care across the globe. This is still what we go back to. So 2007, Jan Sternwald, who's an oncologist, on the public health strategy for palliative care, of which education is one of the fundamental pillars. And in order to get everything else joined up, that role of advocacy is really, really crucial. And I think some of the themes coming through the talks, that actually the case-based discussions on Friday and the talks today, really affirm this model. So what happened in 2017? I mean, I can't believe it's 2017. The request came as to would it be possible to do some online education on Skype. We used then, or we tried to use then, with mixed success as we were learning to navigate Skype. And so we set up a regular time of the week. It was in the UK, it was 8 in the morning or 9 in the morning, depending on the time difference. It was around about lunchtime in Pakistan. And we talked about cases. Just occasionally, if some fundamental paper had come out, or depending on what we've been discussing as a case-based discussion, if there was a really useful journal article that we could do a critical appraisal on. So not just describing the article, but actually critically appraising it for its relevance to our own practice, for myself in the UK and also for colleagues in Pakistan. And we always evaluated the sessions afterwards. So the evaluation, I think, was really important. It's about just at the end, it was about at the end of the sessions, not just logging off and disappearing off to whatever we were doing next. For colleagues in Pakistan, it was the afternoon. For me, it was the start of another day. But actually taking time at that moment to say, right, what were my main learning points? What do I know now as a result of the session that I didn't know before? And there would always be something, whether it was just a reflection on availability of opioids, whether it was a reflection on what do I use in Pakistan for neuropathic pain, whether actually it was a reflection sometimes for me, which was, I'd completely forgotten where one of the adjuvant analgesics, for example, amitriptyline or gabapentin, where they work, how they work. This session's been really important for me. So what are the main learning points? And actually, what difference does it make? How will this affect the immediate clinical practice? I think we're very good in education sessions at evaluating the immediate usefulness, the enjoyment, the what did I think I learned, but actually we need to do that next step to say, actually, okay, what am I going to change? If I see somebody with neuropathic pain, with cancer pain this afternoon, what am I going to change as a result of attending this session? And then what next? So was there, we always talked about actually what are my next learning needs? And how am I going to find them? So how am I going to find the information to address those next learning needs? And then any suggestions for how the session could be developed. So some of our approaches for some of the case-based discussion, we spent a long time talking about the cases. And in fact, what we were talking about was the concept of total pain, the holistic model of the care of the pain of a patient with cancer. And in fact, if we'd thought about the session in advance, we needed to have spent a little bit more time, allowed more time for the concept of the other elements of pain. And very often it would be around things like communication and just thinking of the psychological side of pain, the social side of pain, the spiritual side of pain, but within the context of working within how Pakistan works in terms of culture, in terms of families. How could one make a difference? Because the Western model doesn't always fit. And it's about knowing what the principles are and then how can they fit, how can they be applied. So the sessions have been really exciting, really energizing, really fun. And that's the key about any of the mentoring sessions. I think they've got to be fun. They've got to be enriching. They've got to be something that makes you want to log on the next time, despite our busy days. So the main themes from the sessions over the last 3 years have been communication, whether it's just breaking bad news or whether it's some of the more challenging aspects of communication. Ethics, withdrawing, withholding fluid, like we were talking about on Friday. Lots of discussions around analgesia, the principles of pharmacological management of analgesia, and actually what's available, what might work in Pakistan, allowing for what's available. So how to make the local resources work to the best of one's ability, rather than saying, we haven't got that. It's okay, so what have we got? How can we make it work? We've done some fascinating sessions on bowel obstruction, including the surgical aspects as well as the pharmacological aspects. We've talked about critical appraisal of papers and we've talked about reflection on clinical practice. Two of the attendees, in fact, were also students on the Cardiff course, and that gave us a little bit of additional time and information to be able to talk about some of the aspects around leadership and team working. Because going back to the Jan Stonewall model, education is absolutely vital. But in order to take palliative care forward, to do some of the initiatives that are so important, you need to be able to develop that leadership style and that ability to communicate with funders, with government. So it's sort of advocacy skills, really. So we talked about some of that as well. So our last session was planned for March 2020, and everything changed. And I think everything changed, particularly March to June, just because we were fighting. We were fighting the virus. We were fighting the impact that changes had made to our clinical working lives. So in a sense, everything had to stop while we sorted out how we were going to respond to the virus. My own clinical work in Cardiff became much more complicated. I work in the community as a consultant because the impact of changed oncology clinics and changed GP arrangements has meant that the community palliative care needs were massive. And there was a huge amount of resource went into hospitals, very appropriately, to cope with the influx expected of hospital patients, but no additional resource to the community. So we learnt a lot and we were very busy. But what that meant was that at that time, our sessions had to be just paused. But that's how we regarded them. We regarded them as paused, and it's high time now that we come back together again. So what were the challenges? Because there were challenges that we worked hard to overcome. Timing. So, you know, when you're in the middle of a busy day in Pakistan, it's very difficult sometimes to finish clinic on time and get to the session. I would feel the same if it had been evening time in Pakistan and lunchtime in the UK time. So thinking about the best timing, and that's where almost now setting the clock back. I'm thinking, right, when is the best time going to be to get the most out of the sessions? And we found that if we missed a session for whatever reason, because I was doing these at the start of my day and sometimes with the university put meetings instead, which I would move if I could, but sometimes you couldn't. It just felt if you missed a session, because these were monthly, you never quite caught up. We did, in fact, but it just missing sessions could be difficult. Early on, as we were getting to know each other, it was just that feeling of, okay, it's all very well learning about the principles, but how can we use them? And so we spent a lot of time really finding out what ways could we do things. Palliative care is all about being proactive, isn't it? We don't like it when people say no. We like to find a way to do things around it. And as we started, technology was very tricky. I didn't know much about Skype. I never heard of Zoom in 2017. That was then. This is now. We now know much more about technology. Chris has given a beautiful example of how our learning about using technology for support, for education, for mentoring has had to grow over the last sort of 8 or 9 months. That's really exciting. From our point of view in Cardiff, we had to put 3 weeks of face-to-face teaching online and make it meaningful for the course, including virtual communication skills, which we've managed to do. And some of the things that we've been talking about, that actually with engagement, you can get a meaningful experience from the online environment, they're absolutely true. We can vouch for that. And we've developed some guidance to help our colleagues across Wales, and happy to share it, for really getting the best out of the sessions. So we did have a lot of challenges as we started. In 2018 to 2019, we got a rhythm, and we got our definite curriculum was being covered. And it's very much something that came from the group. So for every session, it would be what's current. What's current? What do we want to talk about? What do we need to talk about? And sometimes I would bring a case that I've been struggling with at this end, mostly around communication, sometimes around cancer pain. For example, cancer pain in the community when somebody did not want to engage with hospitals at all, and what can you do at home? So the sessions needed to be derived from the group. We found that actually, sort of again, to continue from Chris, it's time, temperament, one's own temperament as a facilitator, and that of a student, that of a participant, and the technology. Those were the 3 themes of the challenges. Being focused in the moment. So for the moment that you are online in that session, everything else just needs to wait outside. You are in your zone for that session, and that always worked. And lots of positives. Two-way process. It builds a community of practice. There's lots of impact on patient care. Online can give you lots of diversity. You can bring lots of people together, and it develops that global community, which is so important for a palliative care movement to take shape, grow, and to be sustained, to be resilient. It's got to have that kind of global connection. So, in summary, the way ahead, it's absolutely vital. I think doing mentoring, doing education, but particularly doing mentoring. So giving that chance for actually, how does this make us feel? How can we get the best out of ourselves delivering palliative care? Really important, keeping the patient at the centre And as we're going to hear, is there a role for a formal collaboration and some formal CPD recognition? So I'd just like to say thank you. Thank you to colleagues in Pakistan. We've been travelling a great journey since 2017. I'm sure we've got lots and lots of. Final slide, just before we finish, 20 minutes.
Right. Thanks a lot, Fiona. That was wonderful. I'm sure we'll have more discussion on this when there's time for question and answers in the end. But once again, a big thank you from all of us in Pakistan for all the help you've always been giving in these sessions and the advice. So the next talk we have is on workforce capacity building and the role the Royal College of Physicians can play. And we've got Amy Prothry from who's the head of global outreach for the Royal College of Physicians, London. Can you hear me, Amy? Your mic is still mute, so I don't know. Can you hear me?
I can hear you, Haroon.
Oh, great. Hi, how are you?
I'm good, thank you. How are
Excellent. Good to hear from you. Are you going to share your own slides, or do you want me to do that?
I think it may be safest if you do, if that's okay.
Great.
Thank you.
Okay, so I'll work on that. Just give me a minute to open the presentation. Can you see this, Amy?
I can. Thank you very much.
Great. Excellent.
Okay.
Over to you now.
So good afternoon, everyone. Thank you for inviting me to join you today. My name is Amy Prothero and I'm the Head of Global at the Royal College of Physicians. I'm going to talk to you a little bit about the work and the role that the RCP can play in the important work that's taken place around palliative care in Pakistan. I've been at the RCP for around 10 years, and prior to my role in Global, I was responsible for leading the RCP's work in quality improvement and clinical audit. Before joining the college, I worked in the UK's National Health Service for almost 10 years. Haroon, next slide, please. Thank you. I'll give a brief overview of the RCP for those that may not be familiar with it. The RCP is a professional membership body that is dedicated to improving the practice of medicine. It was established in 1518, and the core mission is to drive improvements in health and healthcare through advocacy, education and research. We champion medical professionalism and leadership, promote person-centred care and drive improvements in clinical practice. We work to improve patient care by developing guidelines for high quality care, setting standards in areas of care, and then measuring that care through the work that we do in our clinical audit and accreditation schemes. We also run quality improvement and patient safety initiatives in a variety of clinical areas to try to support the implementation of change. Our vision is for everyone to have the best possible health and healthcare. And as a leading body for physicians, we work to achieve this by influencing the way that healthcare is designed and delivered, by promoting good health and leading the prevention of ill health across communities, and by supporting physicians to fulfill their own potential. The RCP provides dedicated resources, training and events that is tailored to physicians at different stages of their career and to their individual goals. And it offers a community of supportive colleagues around the world. Next slide, please. So RCP Global is the part of the RCP that I have operational responsibility for. We're focused on members, fellows and activities outside of the UK. The map that's on your screen shows the distribution of our membership around the world. You'll see that South Asia is very well represented in RCP membership, and that Pakistan is currently taking sort of 9th spot in the overall representation of membership outside of the UK. So the RCP has a truly global network with nearly a fifth of our membership based in 119 countries around the world. As a result, our work spans high, middle and low income countries and will range from accreditation work and guideline development in the Middle East, for example, through to clinical skills workshops, delivery in rural Nigeria. We develop and coordinate globally recognised exams and deliver a wide range of projects which are aimed at strengthening health systems and improving medical standards around the globe. Next slide, please. So the delivery of our global work is supported by a Vice President for Global. We have 5 Associate Global Directors, each with a responsibility for 5 different regions of the world. We have 53 international advisors, and these are fellows of the RCP who live and work in country and act as a conduit for information between the RCP and local members and fellows. We have 3 international advisors in Pakistan. And we rely heavily on a volunteer faculty from our membership and beyond who support us with the delivery of this work, so teaching, speaking and examining engagements. RCP Global hosts local events for members and fellows and act as advocates on their behalf in the day-to-day running of the RCP in the UK as well. So we work to strengthen health systems and improve medical standards through the delivery of our clinical and non-clinical training, examples of which will include the palliative care course that we delivered in Lahore last year, which I'll touch on in more detail shortly. And examples of non-clinical training would be faculty development work, for example, that we delivered in Iceland, Switzerland, the United States, or patient safety work that we've delivered in the Gambia. And through my team, we also deliver many joint conferences and CME events, taking part and supporting many more, with a view to sharing best practice and helping to shape the future of healthcare. We do a substantial amount of work in sub-Saharan Africa, where we've been supporting the initiation and growth of a new physician college, the East Central and Southern Africa College of Physicians, which aims to double the number of physicians trained in the region by 2030, alongside work to combat infectious disease and non-communicable diseases. Next slide, please, Haru. So a large element of work that we deliver that is also particularly relevant to this talk is our Medical Training Initiative, or MTI scheme. The MTI scheme supports international medical graduates into time-limited training posts in the UK, and this is done through a specific visa with a maximum of 24 months duration. So the RCP assesses candidates who must meet certain criteria, and likewise we assess training posts in the NHS which also must meet set criteria, and we do this to ensure that we would only be placing very good doctors into very good jobs. It is possible for international medical graduates to come into the UK's NHS through other routes. However, I'd suggest that doctors then are slightly more at risk of being placed into roles that are focused only on service delivery and not necessarily on their training experience. Posts that have not been assessed to be equivalent to UK trainee posts, for example, and when things go wrong, which they can from time to time, a doctor on the RCP MTI scheme has ourselves at the RCP to advocate for them and to support them to find a solution. At the current time, we have over 310 RCP-sponsored MTI doctors from 32 countries working in over 120 hospitals in the UK across 14 regions. There are 2 routes into the MTI scheme. Hospitals can recruit candidates and come to the RCP for GMC and visa sponsorship, and the RCP can also interview candidates ourselves, and then we match them to posts that have been submitted to us from NHS hospitals. Next slide, please. So I'd now like to focus on a specific piece of work that we have been working to deliver collaboratively. In 2019, a generous gift from Dr. Ghulam Jilani Drabu and Mrs. Aisha Jilani Drabu was made to the RCP to undertake 3 important projects. The first was to provide support for the clinical development of physicians and healthcare workers in Pakistan. The second was to provide support for the clinical development of physicians and healthcare workers in Jammu and Kashmir. And the third element was to facilitate the placement of trainees from Pakistan, Jammu and Kashmir into palliative care training posts in the UK through our MTI scheme. Dr. Jilani Drabu is of Kashmiri heritage and was medically trained in Lahore before migrating to Britain in 1957. Dr. and Mrs. Jilani Drabu believe that palliative care is often a work stream that is driven by the personal experience of those working within it, and chose to invest in this area after seeing the excellent care that was provided to their own much-loved son-in-law. They hope to play a part in ensuring the right to the maintenance of human dignity at the end of life for people in Kashmir, Jammu and Pakistan, and we at the RCP are committed to supporting them to do this. So the programme got underway with the delivery of an intensive week of palliative care training, which was delivered in 2019 in Lahore. And after a competitive application process, 20 doctors and 10 nurses were shortlisted for participation. The course was delivered by a mixed UK-Pakistani faculty, and addressed clinical, ethical and religious matters as part of a bespoke curriculum, while stressing the importance of physician wellbeing and resilience. And finally, it also included elements of training the trainer methodology, so that the course attendees were empowered to share the learning and knowledge from the course with their colleagues back at their usual place of work. Plans to deliver an adapted course in Chandigarh this year are currently postponed due to COVID, but the preparatory work is still underway and the work will be ready to proceed as soon as we're able to. Next slide, please. So the third element of this programme of work, in addition to the clinical courses, is the Jilani Drabu MTI Fellowship. This is essentially the creation of a robust pathway for at least one doctor each year from Jammu and Kashmir or Pakistan to come to the UK for 2 years of training through the MTI scheme. We're in the early stages of shaping agreements, we hope, between the RCP and perhaps the Shaukat Khanum hospital in the first instance, but also with organisations in the UK to establish a training pathway where trainees will spend 12 to 18 months of their initial training in Lahore, perhaps under Dr. Hafiz, and then 24 months in the UK training within a palliative care service on the MTI scheme, followed by their final 12 months of training back at home in Pakistan. The scheme will be designed around brain gain and not brain drain. I think it's important to stress this is not a route to a career in the UK. There'll be requirements that the candidates will need to demonstrate at interview. To be able to work in the UK, they'll need 3 years of postgraduate experience, a postgraduate qualification, proficiency in English language demonstrated through IELTS at 7.5 score or OET grade B, and that will need to have been achieved within 2 years of application. They'll need to have been in clinical practice for 3 of the past 5 years and in continuous practice for the 12 months prior to their application to train in the UK. Equally, there'll be requirements on the UK organisation that wishes to host the candidates. They'll need to provide evidence of training and education opportunities that are equivalent to UK trainees. So they'll need to have access to study leave, courses, in-house and on-the-job training. They'll need to be equivalent work patterns, annual leave and salary to a UK trainee. They'll need to be a named educational supervisor, provision of induction, which will be provided also by the RCP. And the RCP will provide free access to the e-portfolio system and offer pastoral care throughout the doctor's stay in the UK and beyond. There'll be regular review by the hospital, the doctor, the RCP and the in-country organisation to ensure progress both in terms of clinical skills and competence, but also teaching and research skills, ethics and clinical governance, audit and QI skills, but also just to support the doctor through a new cultural experience and make sure that they're enjoying themselves. Next slide, please. So finally, what we, what we hope to do through these various elements of work is to support the creation of a community of practice, both within Pakistan and beyond. When it comes to building and improving local health services, we have many examples of returned MTI doctors playing leading roles in this. We have an MTI doctor who returned home to build the first gastroenterology unit, which became a regional referral centre in Lebanon. Another who established specialised neurology services such as neurocognitive and neuroimmunology clinics, neurocritical care unit in Sri Lanka. Another who's led the formation of the first clinical infection group in Nigeria. We hope that in time, the Jilani Drabu MTI Fellowship will go on to record such impressive markers. The Jilani Drabu Champions is the name of the WhatsApp group that resulted from the course in Lahore last year. It's a supportive space where doctors and nurses can seek advice and support from one another and celebrate their successes. We hope to transition this group onto a professional case discussion platform and are seeking funding at the moment through the college to do this. In time, we hope that candidates from the Chandigarh course, doctors on the MTI Fellowship and beyond will join this enthusiastic group. The RCP will continue to facilitate connections for interested parties, both through the Association for Palliative Medicine, who Ian will talk to you about in just a second, and other specialist groups in the UK with interested partners in Pakistan and beyond. And finally, we at the RCP are committed to continue to build these networks and collaborations, and ultimately to continue to support and implement the vision of the Jilani Drabu family. Thank you.
Let's move on to the next slide.
That's me, Harun.
Okay, right, great, thank you. So you've saved some time for us. Thanks a lot for doing that. Right, great, Amy, thanks a lot. And, I must say that this year, not having all the fun we had last year with the Jelani Grabo course and everything, we are missing that. But hopefully, we should be able to pick up from where we ended things last year, and hopefully the plans of starting this fellowship should move ahead. We'll discuss it more in the end of the session, but I'm going to go on to invite our next speaker, who is Dr. Ian Laurie, who's a consultant in palliative medicine, and he's representing the Association for Palliative Medicine of Great Britain and Ireland. I'm really grateful for Ian for having agreed to give this talk. So Ian, are you going to share your own slides, or do you want me to do that?
I'll hopefully be able to share them, Harun.
Excellent. That's great.
Yes.
So over to you.
Well, good afternoon, everyone. I can hardly believe that it's a year since we were in Lahore, and I'm really sorry not to be able to be there in person, although my waistline is very happy not to be there. I had to go on a diet when I came back because of the wonderful hospitality. I wanted to talk this morning about palliative medicine in developing countries, but not only what the APM can do, but also about why it's needed, etc. But first of all, talking a bit about the APM, the Association for Palliative Medicine was begun because of these three distinguished gentlemen, Doctors Derek Doyle, Richard Hilliard and Robert Twycross, who had this vision for an association, a membership association for palliative care. And so the Association for Palliative Care and Hospice Doctors was formed. That's transitioned into the APM, recognised as a specialty in 1987 and narrowly avoided being called terminal care, which I think would have been obviously a huge mistake. And now we're a body of over 1,200 members and growing weekly. The reason that I mention this is because I know that Harun is passionate about palliative medicine being recognised as a specialty in Pakistan, and it shows that it can happen. It takes time, but we in the APM would, and Harun knows this, are very happy to support in any way we can the development of it as a specialty. Thinking about low and middle income countries, we sometimes don't quite understand. We use the phrase, but don't quite understand what it actually means. When you look at the gross national income per capita in these various levels of low, middle, upper middle and high, it shows you the vast disparity in income between the low and high income countries. It's just huge. And the map on the right of your screen just kind of maps out where the low income countries and the middle income countries are. So you can see that places like Australia, Europe and North America are doing very, very well. And we know that in terms of income. But they therefore have a responsibility to help improve the healthcare across the globe in low and middle income countries. We reckon that there's about 40 million people who need palliative care across the world. And the striking figure for me is, yes, 69% are aged over 70. I think we could possibly have estimated that, but that 78 to 80% are from low and middle income countries. So the vast majority of people that need palliative care don't have access to it. Projecting ahead in 40 years' time, that almost half of all deaths will die each year with health-related suffering. And health-related suffering, I don't just mean poor symptom control. I mean the ability to achieve a comfortable death, dying with dignity and respect, and to have quality of life up until the time that they die. And again, over 80% of these will be in low and middle income countries. Why Why do we need to improve palliative care there? Well, yes, to reduce the suffering, physical and psychological, social and spiritual. But we do have a moral imperative to do this because there is this increasing burden of health-related suffering, and we know that the demand is set to grow. The current provision, there's little or no access to palliative care in 42% of countries. And even the other half, the development is very uneven, mostly affecting the middle-income countries. An estimated 20 million people have unmet palliative care needs at the moment. Only 20 countries across the world have achieved high-level integration of palliative care into their mainstream health services. And only one of those is a low and middle-income country, actually Uganda. But while provision of palliative care in, for example, Uganda or other places in Africa, has been good. There's been about a 9% increase up between 2006, 2011, I think last statistics I saw. It's mostly related to the HIV/AIDS epidemic rather than, for example, the care of patients with cancer. So even where there has been development, it's not achieving delivery of palliative care and access to palliative care for most of those who need it. What are the barriers? And I think through the talks this morning, these factors have been mentioned. So education, lack of access to education, lack of opportunity to learn from peers and from mentors, lack of funding and support for education. Access to medications has been mentioned, and again, I know that this is something that's close to Haroon's heart as well. Regulatory restrictions, insufficient funding, lack of a storage and supply infrastructure. It's all contributing to a lack of availability of good symptom control. And it seems daft when almost 60 years ago, the Single Convention on Narcotic Drugs obliged governments to ensure opioid availability for medical purposes while preventing abuse and diversion. And again, the WHO in 2000, updated in 2011, highlight that controlled drugs should be accessible and available to prevent unnecessary suffering. There's also public and professional perception, and this is something we sometimes don't recognise. This reluctance to discuss death or the feeling that palliative care is all about death. If you think about it, say, approximately 80% of African people consult traditional healers, and that can sometimes be associated with unrealistic hopes for cure. In some cultures, even talking about the possibility of death in front of a patient can be seen as a curse or can seen as hastening death. So we've got a lot of work to do, not just developing palliative care services, but actually developing public and professional perceptions about what palliative care is. And then related to that, the cultural, societal, faith influences. Sometimes it can be that certain religions never give up on life, no matter what. Life matters at any cost. So palliative care can be seen as a sort of confusing, unwanted approach to care. So palliative care has been declared as a universal human right, and we know, I suppose we're talking to the interested here, it's one of the most holistic and appropriate approaches for patients with chronic illness. We know that opioids work and that they're effective and cost effective for cancer related pain, and it's on the morphine itself is on the WHO list of essential medications. So therefore, why hasn't palliative care developed as much as it could? And these themes have come through this morning in the various talks as well. We need leadership and advocacy. So international and national organisations supporting countries where palliative care isn't recognised or is in its infancy to try and support them, to try and influence national policies, and that's both palliative care specific, but getting palliative care into other health policies. Sometimes it can be that you have to go in by the back door and try and get into general health policies in order to grow palliative care. International consensus documents I mentioned, and the support of world experts, getting international cancer strategies, so that just as early detection, prevention and cure, which are all pillars of cancer strategies, and palliative care should be that fourth pillar, should be in there as well. There's some evidence that primary care models of palliative care are actually more affordable and achievable than specialist provision at first. And interestingly, I was talking to a physician in Beirut, and I'll mention more about that later, last week, and that was how they started their palliative care provision in Lebanon, was going into primary care and then gradually moving it into hospitals. So that's one thought as well. But also the recognition of local resources, beliefs and customs. And Fiona touched on this earlier. It's not imposing a Western style or a US style or an Australian style of palliative care onto a country. It's actually seeing what they've got already, what they want to do, and how can we add and aid that process. Success stories. India, palliative care isn't really recognised as much as it should be, apart from in Kerala, where they integrated palliative care into primary care in 2008. They've got a big community volunteer system, and most of the palliative care in India happens in Kerala. I mentioned Lebanon as well, and there have been some inroads into secondary care there. Kenya, Malawi, Uganda, good community-based programs which improve the access to palliative care. And there's some good evidence about better total pain control of the psychological, social aspects as well. In China, there's no national policy or funding, but actually there's 200 privately funded hospices in China, and I think over about 10,000 people working in the palliative care sector. So it'll be interesting to see where that goes in terms of national policy. So the role of the APM and its partners, and I've deliberately talked a lot about the need and how we can do things first, but the role of the APM through ELCA, the e-learning for healthcare, with the end-of-life care for all, that is, and the APM administers that, and we're trying to make more modules open to the public. There's going to be an increase up to maybe 25 to 30 modules open to all health professionals. At the moment, it's limited to having a UK NHS email address, but we're actually quite developed in working on getting it available to people with a personal email address, because that we found that when we tried to provide access to all the delegates from last year's course in Lahore, it was going to be prohibitively expensive, and the company that runs it wouldn't give us a discount. So if we can increase the amount of open access modules out of the 160 odd that there are, that will help people in low and middle income countries for whom purchasing access is too expensive. Amy's mentioned the Jelani Drabu, I've spelled it wrong there, Drabu course, and it's just such a shame that we couldn't get to India this year to do it, but Chris and his team have done a fantastic job in developing that course and maintaining the links afterwards, as Amy mentioned. The RCP MTI programme, again, Amy mentioned that, limited in terms of palliative care involvement in that at the moment, partly I think due to hospice funding and the way that medical education for palliative care has been changing. But we're hoping to work with the RCP to see if we can develop MTI initiatives specifically for palliative care. There's a palliative medicine specialty certificate exam, Obviously, it's mostly people who have gone through specialist training in the UK that sit that, but that exam is available as a qualification in palliative care, along with all the various diplomas and master's programmes that many members of the APM feed into. I've repeated myself with the MTI programme there, and a lot more. We're starting to work with RCP Global that Amy heads up. I, as a member of the RCP board, sit on RCP Global Exec, and actually next Thursday, the 12th of November at noon UK time, we will be having a live question and answer session and presentations about palliative care in low and middle income countries. And the people that I mentioned earlier, the countries, we've got representative from Jamaica, representative from Kerala in India, and a representative from Beirut, talking about how they developed their palliative care provision in these difficult areas of the world with little or no funding. And then we can have live question and answers afterwards. So do feel free to register for that on RCP Player next week. I think the main thing that the APM can do, we're not a huge organisation in terms of finances, etc., but is to try and provide through our membership access to resources, access to policy documents, and be advocates for nascent palliative care chapters around the world. I think that we can, through that, we can possibly move palliative care in Pakistan from being, I suppose a Cinderella specialty isn't quite the right term, but to being a fully accepted medical specialty, and we'll provide Haroon and his colleagues with every bit of support we can for that. Thank you very much.
Great. Thanks, Ian. And it's good to see your cats at the end. So thank you very much to all the speakers, because everybody was very disciplined, I must say. Everybody stuck to the time wonderfully well. So we have about 10 minutes for question and answers. One of the questions we've received so far is around palliative medicine training through the MTI scheme. Related to Amy's talk. I'll give a bit of background of it, and then Amy can answer the question. So the question is about, do we need postgraduate experience, or will it be like supra-specialty training? So if we have a degree in internal medicine from the College of Physicians and Surgeons of Pakistan. So the background to this, the specific one that Amy was talking about, is something that we are planning to develop. So that the initial bit of training is done in Pakistan. At the moment, it will be at Shaukat Khanum Hospital in Lahore, but we hope more centers will join into this initiative. I'm already hopeful that Aga Khan will come on board, and I'm sure they will. I know that the palliative care physician from there, Atif, is online as well with us. So once you've done that initial bit of training here, you will have set goals for which we will then put up your CV with the RCP, and the RCP will interview separately. And then if you are accepted into the program, organize a training slot for you in the UK, so that the training that you cannot have in Pakistan can be covered over there. So you'll have specific training goals when you go there, for which you will be assessed, and then you will be able to come back and finish off your training the last year in Pakistan again. But Amy, if you want to add anything to this question.
I think that you've answered that perfectly. Haroon, I'm not sure that there's too much more I would add. I would just say that the criteria for MTI is that there must be a postgraduate qualification, but it doesn't have to specifically be in palliative medicine for you to enter a palliative medicine training post in the UK. But that would make, I think we would prefer to try to offer a more robust package for the fellowship model that you've just described.
Mm-hmm. Right, great. Thanks, Amy. We've got another question from Dr. Atif Wakar, who's our palliative care physician in Aga Khan University, who we heard as one of the experts in the panel discussion on Friday. He's suggesting something on the leadership and advocacy front, saying since there are currently no national palliative care associations or regional palliative care networks to advocate for services and training, we must partner with existing associations in Pakistan. And as an example, he feels Society of Medical Oncology in Pakistan would be an excellent platform to partner with in order to advocate for the palliative care agenda. I'll start with answering a bit of that, and then maybe Ian, you or Chris could give their views on that as well. So we did try and establish a palliative care association of Pakistan. But if you go by the book, it has to be registered by the Charities Association and the Security Exchange Commission and whatnot. And initially I had some support from the hospital administration to do that. But with the amount of expense involved in it, we had to eventually go towards not doing it on a formal platform. So I think maybe, doing it as a branch out of an oncology association might be a good idea to start. But let's see what Ian or Chris or anybody else from the panel, if they want to take this.
I think you're right, Haroon, and until you get to a reasonable size, obviously it's a lot more expensive to do. A small society still has the same sort of activities that it wants to run. I know that, I think that joining up with another specialty is a good idea, to have like a special interest group or special interest forum. The common ones we would think of if we didn't exist in the UK would be oncology or care of the elderly, geriatrics, or primary care in a way. So I suppose it depends on what societies or associations you have in Pakistan. And I suppose it's how open and friendly you think they'll be and welcoming, and you choose your bedfellow carefully. Sort of thing.
Yeah, I agree that's always. I think Chris has unmuted his mic as well. Chris, do you want to add anything?
Yes, absolutely. I think I agree exactly with what everyone said. I suppose you also touched on things earlier, Haroon, which is about getting education amongst the general population. I think in the UK in the 60s and 70s, once people became aware of the benefits of palliative care for themselves and for their families, that's created a huge groundswell. And most of the funding for palliative care services came from that groundswell. So I think there is a two-pronged approach. There's a sort of the carrot of our professional bodies encouraging us to set up training programs and our acceptance into the mainstream, which is great. But there's also the push of the population that needs this as a service. So if we said we didn't have oncology or we didn't have cardiology, that would just not be accepted by the population, or good obstetric care. But somehow we allow bad end-of-life care, and that can't be tolerated. And I think people just aren't aware of what should be available to them. So they know that they should have good obstetric care when they're pregnant, or when they have children, that they have good pediatric care. What people perhaps aren't aware of is that they should also be demanding the same palliative care at the end of their lives. And I think if we can get people to start demanding this, then the political will change and will allow us to start to deliver excellent palliative care.
Great. Yeah, I mean, I agree with that. And somehow it's always been a neglected thing in Pakistan, and it continues to be like that. And I think you're right that one of the most important thing is raising the awareness of public that this is an important aspect of medical care, and that needs to be available to everybody. And as I mentioned, that we've already, we're lucky that we've had a very good donor family who's been working with us to make a documentary around introducing palliative care to the general public, and they've also been working with us to maybe try and have small communications published in newspapers and various periodicals so that people try and understand what it is all about. And while we are talking on that, we have a comment from Dr. Sadaf Mudassir. I'll just introduce her. I'm unable to get her mic to work from here because I think I'm not allowed to do that. But she is a general practitioner in the UK who set up a Shaheen Palliative Care Foundation, and she has been working tirelessly to try and improve the palliative care education and service development in Pakistan through her charity, which is the Shine Palliative Care Project. And she has managed to set up a palliative care certificate course through a university in Peshawar in Pakistan. That's something that I think she just wants us to mention it here so that people are aware that this forum exists and the palliative care certificate course is available for interested doctors and nurses who are part of the audience to join. We also have a question from Dr. Wamis Qadri, who is the gentleman that I've been referring to, who's been helping us produce a documentary on introducing palliative care to the public. So thanks, Wamis, for joining into this session. And he has mentioned that morphine is on the WHO essential list of medicines, but it is very rarely available in Pakistan. Even the biggest tertiary care hospitals in Pakistan do not have morphine availability for cancer patients. He wants to ask the panel members if they have any suggestions on how to improve the availability of morphine in Pakistan, whether any of them has any experience in terms of having done that for their own country or helping it for some other place. So does anybody want to take that up?
Well, some of the literature from the low and middle income countries have mentioned some surprising places that have got better access. Some of the suggestions were that it's a government controlled company that supplies it rather than it being private companies. That I can't remember which country that was. There was a couple of them, but so that the government has more control. I think it's almost, before you get the supply, you need the infrastructure. So that's the what are your regulations going to be? How's it going to be stored? How are people going to be able to access it? So before you even think of getting the drug, you have to have that structure in place. And I know that was mentioned in a couple of the papers. So I think it's one of those kind of long journeys, well, as you know yourself, Harun, but it's a journey that's worth taking but I think it's all the preparatory work. And just as Chris was saying there, is making people aware of the importance of palliative care and educating them about that. And then how we deliver palliative care. And we've got a lot of evidence about opioids, etc. And it's convincing governments that way, rather than just saying we want access and supply the medicine. We might have to do a lot of education work beforehand and preparatory work so that opioids do become acceptable.
Yeah, I agree. I mean, that's the approach that we have taken, and I mentioned it on Friday as well, and I think we discussed it last year in a couple of our meetings as well. That we've produced we've tried to produce a paper for the Parliament to address it from the political front in terms of availability of medications, and we've also collaborated with Dr. Qadri, who has been very instrumental in setting up communication out for the public. So we hope that over the next year, these 2 or 3 things will work better towards improving access to palliative care, as well as drugs mostly. And I think a significant thing that we are hoping for is, because our previous chief executive is the current Minister for Health, so we've got a bit of a listening ear now. So we hope that this will get better now. Maybe in the next 12 months, we'll see more progress than what we have seen so far. And as I said, that the curriculum that we wrote out for palliative medicine, that also has been provisionally approved by the College of Physicians and Surgeons of Pakistan. So that would be a big step whenever it finally happens. So I'm told that they have their next meeting in January, in which it might happen. There are 2 questions which are exactly the same from 2 different doctors, and I think that's an interesting question that always trainees from Pakistan seem to ask. Is the pass percentage for UK and international candidates the same for the specialty certificate exam in palliative care? So who in the panel wants to take that up? I think it's available on the RCP website, the pass percentage, but I'm not sure. I mean,
on a Sunday morning in the UK, I cannot tell you, I'm afraid. It's not on the top of my head. I will try and find out.
Yeah. I'm just guessing off the top of my head that probably it'll be higher for people who have trained in the UK, because obviously the exam is UK centric and covers a lot of ethical and legal issues which are very relevant to people who have practiced in UK, and somebody who's not practiced there may not be aware of those components. Fiona, do you want to add anything to that with regards to the SCE?
No, not regards to the SCE. I've got another reflection to add when questions are finished, but no, I haven't got any other secret information, I'm afraid.
Right, so we'll turn it over to you, because I think we're running out of time in the last 5 minutes of the session. So if you want to comment.
Thank you. It was only just to add sort of really to some of the questions that have come. Dame Cicely Saunders had a great phrase when she was developing palliative medicine back in the early 60s, which is just to be untidily about. And I think at the start of this sort of a journey to develop palliative medicine, to get your movement together, to gather momentum, but to keep it resilient, it will feel very disjointed, because you're just getting the communication, the networks going. But I think what's really energizing and vibrant about it is a meeting such as this brings expertise together and brings passion together. So you've got people who are here because we all want to help develop palliative care in different ways. There we are. So knowing that it's going to feel a bit muddly is the first thing. Thinking of the public health model in countries all over the world. If you talk to people from the Worldwide Hospice Palliative Care Alliance, it's that public health model that has been central to success of developing palliative care globally. So it's almost worth, in what at the moment needs to be an informal group because of all the challenges that can be encountered when setting up a national organisation. And don't forget, people will be very wary of a national organisation if they don't understand what palliative care is. But everybody has got a role to play. Get posters out to meetings, write letters to journals, talk with colleagues in different countries. You need to get the world behind palliative care as the concept in Pakistan, and to help build it that way. So it's a real team. It's a team sport, palliative care. This is an international team sport, and as the journey develops, what I've noticed in different parts of the world is that there's sometimes emerged people who are natural advocates and natural leaders because of the connections. Some people are wired to make connections. That's how they work. Use that person for the advocacy. Some people are really wired for research. Use that person to help be the go-to person for research outputs. It doesn't have to be much, but just little bits of research outputs to international meetings, really important. Some people are good organisers. So it's team working and thinking now, right, here we are in November at this great symposium. Where can we put the next 2 days of palliative care? What's the next international meeting that we can incorporate in? So just a reflection from working alongside many colleagues from many different countries and building on what Ian has been saying, what Amy has been saying, and what Chris has been saying. I think there's so much opportunity, but it will feel disjointed, but we need to get the message out that we're working to make it better. We're working to improve it. We need everybody to come along on this journey with us.
Yeah, I mean, I agree, Fiona, and that's a lovely reflection for this session. We've got a couple of people from the attendees who have raised their hands, so if they can hear me, I would really request them to please post their questions in the Q&A section, and I will take up those questions and mention them. I'll be really grateful if you could do that, because of certain logistic reasons, we are unable to give the mic over to the attendees at the moment. So if you could put your questions over there, then we'll take them up. We still have another 5 minutes or so. So if you could put your questions up, we will definitely take them up. In the interim, just from a perspective of the discussion that we were doing around the MTI scheme, and about getting trainees from here to go to the UK, gain experience, and then come back. How does the forum feel about, I mean, Fiona set up this monthly thing that I know at least 3 or 4 of our own doctors in Shaukat Khanum have been regularly attending and benefiting from. Do you think now with this COVID and everything and the way virtual conferences are, maybe we could set up some sort of a, once a quarter or something, or some sort of a global journal club or something like that? And I think these problems are fairly similar for a lot of people across the countries, various countries. When I read literature from the African countries and most Asian countries, there's a lot of difficulty with regards to opioid availability and human resource availability. Do you think we could do something like that through the platform of either the RCP or the APM? Ian, Amy, what do you guys feel about that?
I think it's certainly something I'm looking at Amy's screen on my screen, that we could take to RCP Global in a way. But it's more just for the use of the technology. But I don't know, Amy, what your thoughts are.
I think it's a fantastic idea. I think it feeds into our desire to want to create that community of practice, and I'd be very happy to take that forward. Yes, yeah.
Ian,
Yeah.
I wonder if I can ask you a question. I'm being a bit mean here. I mean, with the APM, would it be possible, because there's so many training things that go on with our members every day, if not every week, and if those were opened up to the wider healthcare economy, so if we know, say for the group that came over to Lahore last year, that we're all taking part in loads of different educational events, and if we just publicize those on our WhatsApp group so that people could drop in if they wanted to, they could do a bit of a pick and mix, and if we perhaps develop that through the APM, there aren't any resource issues because we're already teaching and we're using these online portals. Now, this meeting is such a great example of this being relatively cost neutral in many respects. So if we're running events already, why don't we just open those up to people so that they can choose the events that they want to take part in, and they can find events that are applicable to their practice?
That's something I can bring up at our next APM board meeting, and I'll send our treasurer your way, Chris, as well, because he'll have some things to say. But I'm sure there are ways that we could look at online education, just like the things that Fiona, the wonderful work that Fiona's been doing for years. How can we develop that further? And I think maybe I step down as president in March. I may have slightly more time to see if we can help the APM develop that further, but I will take it to the board.
Thanks.
Great. Excellent. We have one more question, and I think after that we'll wrap up. The question is, how can oncology pharmacy teams help promote or set palliative care setups in Pakistan? Is there any such example from around the world? If anybody from the panel can share their thoughts on that. Tough to say, but I feel generally palliative care is very multidisciplinary, and pharmacists are a very integral part of any palliative care team. So I feel, yes, pharmacy associations could help be the platform where we can project palliative care into the wider health community. What does anybody else feel? Yeah, Fiona?
Just if you need to talk to people, particularly in Uganda, Anne Merriman, right. Setting up Hospice Africa Uganda, working with pharmacists and the pharmacy organisations in that country to help. In fact, they were able to develop their own supply and processes for making oral morphine available. So pharmacy has an integral part to play in how to establish the availability of strong opioids. So absolutely, and I would talk with the African Palliative Care Association, but it's particularly Uganda as a country who will help here. Really important. Good idea.
Okay. And I think on this note, we'll probably wrap up. We have another comment from Dr. Sadaf Mudassir, who I already introduced, that they are trying to set up their palliative care certificate course using UK and US based faculty in other universities in Multan and Rawalpindi, which are pretty big setups or cities in Pakistan. So it's been, in the end, I'd like to thank all the panelists, because it's been a wonderful discussion, and it's always is nice to share ideas about where to take things further. I know I've been bothering all of you every now and then with a lot of emails back and forth, trying to develop ideas and work forward with these things. And I'm grateful to the entire panel for always being very supportive and for joining us here today as well, especially on Friday when it was 6 in the morning. I felt very guilty writing to you all about it, but I'm really grateful everybody made an effort, joined us, and we had a wonderful discussion and an event. So thank you all, everyone. And hopefully maybe next year we'll have a face-to-face session once we have the vaccine or the virus goes away. So thanks once again, and hopefully see you all again next year. Thank you. Bye-bye.